Okay, so we'll go ahead and get started. Want to welcome everyone today. My name is Dr. Samir Sinha, and I'm the Director of Health Policy Research at the National Institute on Aging. Want to welcome you to our webinar today, and we'll go to our next slide. I just wanted to note that all audience members' microphones have been muted. So if you have any questions for our speakers, please use the Q&A box that you'll find at the bottom of the screen, and you can insert any of the questions that you have for our speakers. And please insert them at any time during the webinar as well, so that we can have them ready for our Q&A section at the end. And if you have any technical issues, please let us know in the chat box at the bottom of your screen as well. So again, thank you for joining us today. Go to our next slide. We just want to begin by acknowledging that the National Institute on Aging is based in Toronto, which is in the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabe, the Mississaugas, and the Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. We'll go to the next slide. So again, I want to welcome everybody to our webinar today. It's entitled Equity in Dementia Care, and specifically we're hosting it this month because this month is also Pride Month. So happy Pride, everyone! And I'm thrilled that I'm joined today with some exceptional panelists who you'll be hearing from shortly. I just want to introduce the four people that we have today. The first is Dr. Ashley Flanagan. She is a senior knowledge broker at the Ontario Centres for Learning, Research and Innovation in Long-Term Care, or the CLRI, at Briere Health, where she leads the equity, diversion, inclusion, and belonging initiatives across Ontario's long-term care sector. She holds a PhD in aging, health, and well-being from the University of Waterloo, with research specializing in the experiences of 2S LGBTQI adults. And Ash's work, including her collaborations with EGAL on coming out and coming into living with dementia, has shaped national campaigns, caregiver e-learning modules, and policy recommendations supporting the 2S LGBTQI plus and older adults. She's a recognized leader in aging and health equity. She bridges research, practice, and policy to advancing and affirming and inclusive care. And I'm proud to say that she's a familiar face to our NIA audiences as well, as Ashley was one of our research fellows and one of our managers of research on my team here at the NIA. So we welcome her back, and she continues to support us as an associate fellow. The next person I want to introduce is Ngozi Iranya. Ngozi is the Director of Health Equity and Access with the Alzheimer's Society of Ontario, and in her role, she develops and supports the creation of equity-focused programs and resources across 26 local Alzheimer's societies in the province to better support equity deserving populations. She also supports equity deserving communities to address stigma reduction and dementia awareness across Canada. She's a public speaker and dementia advocate. Dr. Iranya also I've already said that you've graduated, but she is a PhD candidate currently at York University in Health Policy and Equity Studies, where her research focuses on experiences of dementia in the Black community using an intersectional lens. She was a caregiver to Dr. Felix Iranya, her father, who lived with dementia for almost 18 years. He is the inspiration for her work. Next, I want to introduce Dr. Navjot Gil Chawla. She's a research and her research and advocacy focus on advancing equity in dementia care and strengthening culturally inclusive approaches to research, service delivery, and knowledge translation. She holds a PhD in public health, specializing in aging, health, and well-being from the University of Waterloo. Her doctoral research examined the experiences of South Asian Canadians living with dementia and their care partners, offering insights into how culture, language, stigma, and systemic barriers shape dementia care. Navjot has contributed to advisory and co-design committees focused on adapting and developing dementia resources with and for diverse communities. In her current role with the Alzheimer's Society of Alberta and Northwest Territories, she supports the expansion of dementia care services for ethno-racial communities across the province, and her work bridges research, advocacy, community engagement, and practice to advance culturally responsive and equitable care. So I want to again thank each of the other members of our esteemed panel today, and we're all going to be sharing first some slides and insights around equity and dementia care. And we're going to be taking a conversational approach. So what we're going to do is we're going to introduce some of the concepts first. Each of our panelists is going to take turns kind of introducing various aspects about the issues that we're going to raise. We're going to end the session then with an audience Q&A, but I'll have a chance to ask some further questions of our panelists first. And so here we go. So let's get into our first slide. So for some ground rules, I guess, it's always helpful when we use the term equity and equality is to help understand what do we mean. So there's a real nice pictorial diagram here that helps explain the difference between equality and equity. Because equity itself, it aims to ensure that everyone's rights and opportunities by treating all people the same. That's when we think about equality, whereas equity aims to ensure that everyone has access to the resources and opportunities tailored to their specific needs to achieve equal outcomes. And I love this picture because I think it helps really determine what equality versus equity really seeks to do. So equity itself recognizes systemic disadvantages and it provides personalized supports to create a level playing field. And finally, I want to also raise the idea of intersectionality because it explores how social identities create unique compounded systems of discrimination or privilege as well. Okay, so with those definitions, I want to get into our first theme that I wanted us to discuss. And the first theme is really about stigma itself. Because what do we mean by stigma? It's the negative attitudes, beliefs, or behaviors about or towards a group of people because of their situation in life or certain characteristics. Stigma, it also includes discrimination, prejudice, judgments, and stereotypes as well. It involves labeling and devaluing individuals, leading to social exclusion, shame, and restricted opportunities. And types of stigma can include self-stigma, public or social stigma, and structural stigma as well. So we'll move on to, because I want to now invite some of our panelists to talk a little bit about these pieces first. And I think Nav, you're going to kick it off.
Yes, thank you so much, Samir. So when we talk about stigma, I just kind of to touch a little bit about how I've seen during my work and experience within the South Asian community, specifically. So when we talk about stigma, we know stigma is umbrella across dementia when it comes, stigma exists whether you're, regardless of which community you're from, stigma is present regardless. But when we look at certain communities, it kind of changes how that stigma comes through. So, for example, within South Asian communities, a lot of the time I notice when we look at dementia, Alzheimer's as a spectrum, we have our cognitive symptoms that come through, right, where the forgetfulness comes around. But then we also have the behavioral symptoms, where the exit seeking happens or the visual auditory hallucinations. When I was talking to the participants, it often seemed like people were almost okay with the cognitive symptoms that were coming because it was very easy for them to normalize those, right? Like, mom is just getting older. That's okay. And people would fill in those gaps for that person. But it's when those behavioral symptoms come in is where you really see that stigma come through. And it's interesting because when we get into the second theme, I'll come back to this because they're somehow interlinked. It also comes from that awareness piece, right? When you're not aware of what something is, it's easy to kind of find your own definition or understanding of what you believe it to be. So, for example, and when I say South Asian communities, I also want to clarify that it's a very diverse group. So it's not generalizable across the entire subcontinent. So in some South Asian communities, for example, stigma shows up in a very religious form. So when someone is living with dementia and, they may be talking to themselves or having those auditory hallucinations, it's seen as, oh, they're developing a deeper connection to God. That's okay, let them be. Or in particular, the Bangladeshi community, people often see dementia as a suffering, and they believe it is okay for someone to suffer because once they pass living with dementia, they'll attain heaven. So some of these ways that it's stigmatized and it becomes more nuanced once those behavioral pieces. Even when I was talking to physicians during my research, physicians would often be like, "Oh yeah," when we would tell someone the diagnosis of dementia, they'll be like, "Okay, memory, they're forgetting. That's okay." But then a few months later, they will come and they're like, why is dad talking to himself? Why is dad sitting in front of a mirror and doing this? Or, why is dad pointing at the wall and saying so and so? So it's when those behavior symptoms come and it becomes very stigmatized to where it's almost seen as, oh, well, dad is going crazy or mom is, going mad. So those terms that are stigmatizing usually start getting more attached. And sometimes, like the quote I have up on the screen, some care partners talked about how they would explain to, people around them that this is part of the diagnosis my spouse or parent has. And people would be like, yeah, yeah, we understand. We're so sorry for you. But then still they would expect, whenever, like, for example, one of the care partners always took their mom to the Jamaat Khana, which is the mosque, for the evening prayers. But when mom acted a certain way, there were always questions and fingers being pointed of why she's doing something a certain way. And that all stemmed from that stigma that is so pervasive across the community when it comes to understanding Alzheimer's and dementia. You're muted, Samir. Yeah.
Thank you, Nav. So we're going to go on to our next speaker in Ghazi.
Thanks so much. I think it's really important to recognize within each of these communities that we're talking about, there's a lot of diversity within the communities. It's not one monolith. So when we say South Asian community, there's more than one type of South Asian community, and same very much so in the Black community, especially in Canada, when we have a trifecta of people from Caribbean backgrounds, African backgrounds, and those who are generational Black Canadians. But within that diversity, there's common theme of around disclosing information, like taking your business outside, as they say. But so when you think about stigma with dementia, dementia is very much construed as a negative thing for the most part. And we see this common throughout all of the communities, ones I just described. And I find it to be sort of in two forms, both external to the community and external to the community. And it's layered when we think about the ways that how that happens. So internally in the community, dementia and the research that we've seen, the research that I'm conducting is very much seen as a negative thing. And that negative thing can be attributed to a variety of reasons. But what I've seen most prominently is this sort of mental health issue, negative connotations of dementia and then in a mental health sphere, or even connected to social, cultural and social and spiritual kind of sources, like it's a curse, you've done something against God, and that sort of thing. So, in that respect, people don't want to share even what they're feeling inside because they don't want to get that sort of reaction from their family members and their friends and being ostracized. We have seen people, once they disclose, family stops coming around, family stops talking to them. That last quote there, families are not getting in touch because of stigma, that's actually from a Black caregiver, but we have seen that. Externally, when we talk about stigma, people have reported that healthcare professionals stigmatize what they're going through when they go to get support and get help. And that additional kind of stigma, being seen as less than, being seen as weak, can also play within the Black community perception of self and perception of self within the broader society. So, stigma can also lead to not wanting to get a diagnosis, delays in getting a diagnosis, not disclosing that diagnosis, and it can expand and sort of really take the dementia journey and the caregiving journey into a much more negative sort of space, and making it harder to really understand how to get those supports and manage the symptoms and the trajectory of the disease. So stigma is one thing that we need to, I think, collectively, writ large, need to really focus on when it comes to dementia and healthy aging and cognitive issues so that people can actually get access to services as they need it without fear of judgment, without fear of ostracification, without fear of being rejected.
Thank you, Ngazi.
You're welcome.
Ashley, you wanted to talk about stigma as well.
Yeah, and I'd actually like to build on what Navjot and Ngozi have been sharing, and first off highlight once again that there's also immense diversity in 2S LGBTQ communities. And for 2S LGBTQI people, stigma kind of arrives on multiple levels and layers as well. So there's, as we've been talking about, there's stigma attached to dementia, thinking about disclosure and adapting to living with dementia and caring for someone who is living with dementia. There's stigma also attached to being a member of the 2S LGBTQI community, of being queer. As the quote on the screen here, which is from our Coming Out and Coming In to Living with Dementia report, demonstrates that kind of overlapping stigma that happens, and the need to educate the general population about dementia and also about 2S LGBTQI communities. And so it's kind of doubly stigmatizing, compounding, doubly hit, as the quote says there. And then I'd also like to touch on there's the structural aspect of stigma, and that stigma is baked into our care and healthcare systems as well. When it comes to 2S LGBTQI communities, there's forms that erase their identities and their relationships. There's the default setting of assuming someone who is supporting the person living with dementia as a family member or a sibling or a child, and assumptions around who has decision-making authority. There's a lot of things when it comes to the structural stigma that 2S LGBTQI communities face when it comes to dementia. And so these experiences, as we've heard, aren't necessarily happening in isolation. They're adding up, they're multiplying, they're compounding. And so as for 2S LGBTQI communities, when we're coming into spaces, we're carrying that history, we're carrying those experiences with us into encounters with healthcare and social care services. And so that really impacts whether there's the decision to seek care or the decision to avoid and seek support elsewhere as well.
Thank you so much, Ash. So now we want to go into our second theme, everyone, and we want to talk about awareness. And so in ethno-racial communities, dementia awareness varies across and within communities. And we talked about the diversity of communities within even just some of the communities we're discussing. And that can be shaped by language, by culture, migration experiences, age, and familiarity with the healthcare system. We also know that effective awareness work needs to build on what communities already know while creating safe, culturally meaningful ways to talk about dementia as well. And so there are consequences of poor awareness as well. And I think this is where we're going to have some of our colleagues to start to talk about this. And so what I want to do is invite Ngozi. I think you're going to start with this.
I have so much to say and not enough time to say it. I want to also preface that these themes that the audience is going to be going with us on this journey talking about, they're all connected. They don't exist in silos. When we talk about stigma, awareness, and the next theme, you're going to see connecting here. So when we talk about awareness or lack of awareness in the Black community, it is connected to stigma. And it is connected to the way in which Black communities have been positioned in society, especially in the North American context. So something like dementia, and the research has shown, some research has shown that dementia is very much an outside kind of condition. It doesn't belong in the Black community, it doesn't happen to us, etc. So that's one dimension of awareness because it's not something that Black people have been engaged with typically, historically, when it comes to dementia, cognitive deficits, etc. And the stigma around being Black and having cognitive deficit is something that a lot of people don't wish to engage with. So, there's an added layer to why there's lack of awareness in the Black community. Also, thinking about the way dementia has been traditionally presented to the world. It hasn't been presented in a very inclusive way, which adds to people feeling like it doesn't really belong to me, it doesn't really speak to me. And so, not being able to know exactly what dementia is and isn't, then a lot of other ideas fill that space. So within the Black community, with a lot of communities, I think, we see that dementia is seen as a normal part of aging. It's not, but they think, oh, I'm getting older. It's just what happens. Off we go and get on with it, sort of thing. And that obviously has consequences in getting, diagnosis, right supports, right care, etc. And even really preventatively. So not knowing what it is, you don't really know how to prevent it. You don't really know how to engage in lifestyle activities that are going to contribute to healthy aging. And so the consequences are, the impact of sort of more upstream approaches to why there is a lack of awareness within these communities. And that has to do with sometimes internally and culturally, and sometimes it has to do with a structural sort of more broader sense of how to get dementia information out to different populations and different groups.
Perfect. Ash, would you like to say a few words?
Yeah, thanks, Samir. And so building on this kind of idea around dementia awareness within communities, I think our research also found that the reverse is equally true when it comes to 2S LGBTQI experiences, in that 2S LGBTQI experiences are almost entirely absent from kind of more of the conversation around dementia education and outreach materials, with the exception of some unique and targeted programs that are popping up across the country. But kind of broadly, the result is that people navigating both a queer identity, a 2S LGBTQI identity, and a dementia diagnosis, or caring for someone living with dementia, they can often feel like they have to choose which parts of themselves to bring into which room. And so that can be really challenging when you're not seen as your whole self in a space, and especially when you're looking for support. And then also, when it comes to that poor awareness of 2S LGBTQI experiences within dementia education and outreach materials, one of the most distinctive findings that we had in our research was what folks called coming in to living with dementia. So for 2S LGBTQI people, receiving a diagnosis and adapting to living with dementia felt like it directly paralleled their experiences of coming out of the closet. So thinking about the potential rejection, the loss of relationships, having to rebuild your identity, and the reliance on chosen family as a primary support network. So coming into living with dementia really triggered some of those same dynamics for folks. For people who had already lived through coming out, the experience of coming into living with dementia was very real. And then one last thing that I'll say is that there's also a really specific fear within 2S LGBTQI communities that kind of resonates a little bit differently, in the sense that there is this fear that as dementia progresses, as cognitive decline advances and regresses into earlier memories, a person may forget their post coming out life entirely. That means forgetting their identity, forgetting their partner, forgetting the world that they've built and worked so hard to build as well. And that's where you'll see on the screen the caregiver quote, in the sense that with dementia, the brain regresses into what it knows, and our 25 years together is starting to go. So the grief and the fear and the lack of awareness around cognitive decline is really really real. And it's that fear of having that really authentic part of your life erased by your own mind as well. So I think it's something that kind of the work that, or what I want to bring to this group, is having that awareness that there's a lot of fears within the 2S LGBTQI community that we can be aware of as we move and engage with 2S LGBTQI communities.
Thank you so much, Ash. And so we know the consequences of poor awareness are that participants frequently are referred to the cultural barriers they face, describing, you know, how it is in our culture, as a common phrase when reflecting on their challenges. I certainly have this in my practice, where sometimes, when we're talking about how do we navigate a dementia care journey, the issues of culture, all these dynamics that have just been spoken up, I've seen all of it in my practice with my patients. And so when we look at the next point, I think it's important that we know that they explained that within their cultural setting that there was little understanding of what dementia truly was, and as a result, symptoms were often minimized. And I think, am I speaking to Nevjot's slides here? So Nevjot, why don't you take it on from here?
Yeah, no, thank you, Samir. So similar, I just wanted to kind of to what Ngozi said about these are very interconnected. So when I like to see stigma and awareness as being this really toxic cycle where there is lack of awareness, which feeds into the stigma because it's so stigmatized, it feeds into the lack of awareness. But it's very important to understand. So I'll talk about this in two pieces. And then I'll touch about the thing as well because there's an interesting story to that, but I'll keep it short. So first, we want to look at the causes. Why does this awareness happen in certain communities? As Ngazi said, it's very like, I've heard it from so many people. Oh, this is such a Western disease. I've never, like, back home, I never heard of it. Why don't people hear about it back home? When you look at the South Asian subcontinent, over 2 centuries of colonization, followed by the partition and the violence that ensued in the wars, really destabilized that region. And when we look at the healthcare outcomes because of all of the colonization and the consequences of it, we see how long was the life expectancy, even looking 2 generations before people often never lived beyond 50s and 60s. Even my grandparents' parents lived into their 50s. So, when we look at the developing nations, which is a consequence of colonization, the health outcomes are very different. That's why, and one of the biggest risk factors we want to call it for dementia and Alzheimer's is age. So when you did not see that aging, dementia was rarely heard of back home. So that's one of the pieces where people like, I've never heard of it. I think the other piece is more internal of how family structures work in most, and I say most South Asian communities, again, there are differences across, is it's a multi-generational living. So, the pieces where you pick up those small pieces where you might see something is not right or this is not normal part of aging is often masked because of how the household functions. So, for example, when a son is married, his wife comes in. So now the son and the daughter-in-law are managing the household, the finances, the food. So you don't see dad making that slip with his finances because, he's no longer managing the finances. Or you don't see mom struggling to make a cup of chai in the morning or tea because, she no longer does it. So these are some of those pieces. And I think the biggest cause is just the lack of resources. Of the information that there is such lack of information for someone who doesn't speak English and does not relate to the Western culture to be able to go grab a flyer or a resource and understand what it means. I've heard from physicians during my research who feel like they're letting down their patients because they do not have resources on hand that they can hand and believe that the person will read through it and see themselves being reflected in those resources. Even if it's translated, you still have images of a European couple, or the examples are not relevant, and people are not really able to connect to this. Sorry. And the consequences we get is then people are often, very late into the progression when they show up to a physician. And again, even from my own experiences, when I was trying to recruit someone living with dementia to come talk to me, I more often than not heard from care partners, well, by the time we found out dad had Alzheimer's, it was already, you can talk to him, but he's not really talking much these days. Even physicians, one of the biggest theme that came out when I interviewed was talking about how late their patients from South Asian communities presented because they never showed up when mom was just forgetting to make a cup of tea. They showed up when mom no longer knew where the restroom was. So, and these are a lot of those cultural pieces that come in. And I think, Samir, the piece that you talked to, you know how it is in our culture. It's almost a double whammy. As a researcher in that moment, it's very easy for me, and I'm sure for you as well. It provides comfort knowing the person you're talking to from your culture. They don't have to unpack everything to you, right? So it provides them with that comfort. But when it comes as a researcher, especially for me, going back, analyzing all that data, now I had to unpack that to an audience who may not necessarily understand what those nuances are, right? So, and we can also see this as a barrier of the importance of having physicians, services, people who support that language and culture, because then you don't have to sit there and unpack why long-term care home options are not an option. Like so many times, my mom, who's a care partner to my grandmom, has refused services. She's like, I just don't have it in me to sit there and explain to a doctor why I can't do something a certain way. She's like, it's just too much. And the burden should not be on the community, the person, to unpack all of that. It should be built into the system where we're able to understand where they're coming from and respect their background and be able to provide the care that's aligned with it.
No, well said, and certainly, in relation to that, right? It's also being able to not only have that person not have to unpack, kind of those aspects, but to be understood. And when you're understood, then you can actually have the next level of conversation where I can sometimes say culture to culture, yes, I know. However, here's
Yeah.
other things we need to think about. So it's kind of how regressive we are, especially when people can't even bring themselves and their situations to be understood. So we'll now get on to our third and final theme today, which is health and social care systems and services. And because when we think about health and social care systems, we know that they're not experienced equally by all. So when we think about it, there are systemic and structural barriers that can shape who receives care, what kind of care they receive, and how safe they feel accessing it. And gaps in culturally safe and affirming care can result in delayed or misdiagnoses, inadequate pain and symptom management, disengagement from care services, and poor health outcomes. And as Ngozi said before, these aren't separate concepts. These are all, intermingled with one another, and in that way. And so to kick off just some further discussion on this, we've got Ash up first.
Thanks, Samir. And I think I want to just start off by saying the barriers, the challenges that we've heard like across the previous two themes, thinking about stigma, thinking about gaps in awareness, they don't disappear when someone walks into a healthcare or social care setting, right? Like as we've been talking about, everything is connected. And for 2S LGBTQI people, health and social care systems often actually compound the issues and the barriers and the stigma that folks are experiencing, because the systems as we know them today are functioning exactly the way that they were designed. And so what that means in practice is for 2S LGBTQI communities, a lifetime of harm. So thinking about criminalization of their identities throughout history, the way that the height of the AIDS crisis was handled and the refusals of care means that many 2S LGBTQI older adults avoid seeking care until they're in crisis, until it is often a little too late. And so it isn't a preference for them. It isn't a hesitation. It's a learned response to a system that has historically harmed, has dismissed, has excluded them. So denying them care, mistaking their partners and their parents, their partners as their parents or their children, excluding their chosen family, and not recognizing the networks of support that folks have. And so even when participants in the work that I did described positive care encounters and experiences, the background noise of that anticipated harm or that anticipated discrimination never really fully disappeared. And you can see that in the quote on your screen, for folks always thinking that they're always anticipating something homophobic might happen, or some comment might be made, or some misunderstanding will happen. And so the labor of that, the cognitive, the emotional labor that folks, 2S LGBTQI folks, carry into every encounter with health and social care services, regardless of how welcoming a provider actually is really real. And like Navjot said earlier, the task and really the burden of educating providers, of educating folks, of explaining your histories, of explaining some of the apprehensions and the avoidance, shouldn't fall on people living with dementia, shouldn't fall on the patients, the carers themselves. And so that is it's really a failure of our systems up until this point. And so the question that I would hope folks can kind of start thinking about after today is that it's not just, are we welcoming, are we appearing to be welcoming to 2S LGBTQI people? It's, have we designed the processes? Are the ways that we are welcoming or trying to welcome folks into our spaces, are they processes that folks can trust, that their full identity will be respected? Yeah, so I'll leave it there for now.
Thanks, Ash. Nav, I think you're next up.
You're muted, Nav.
So of course I am. This was bound to happen. Um, Thank you, Ash. So one of the pieces that I've seen with my current role, with my research and engaging with the community, has been around language and culture. With dementia, we know there is no cure at the moment with Alzheimer's, right? The best we can do is provide that quality of life that we have that thing that you can live well with dementia. But how can you live well with dementia when the system is not designed to support you to live well with dementia, right? I still remember one of the interviews I conducted, and the quote is up on the screen, and I want you to focus on the last line. When I walked in and I greeted that person, in their language, they started crying. The person living with dementia started crying. So it was a dual interview with the care partner and the person living with dementia. So the care partner talked about how when their person's condition progressed, they tried to get in touch to get some resources, but they could not find anyone who could talk to the person living with dementia in the language. And they said, "You are the very first person who has spoken to her in her language since she was diagnosed." So the first half an hour to 45 minutes of my interview was just sitting there and sharing resources and explaining to the person living with dementia what is Alzheimer's disease, basically in Hindi. So, the resources that are needed. And then it's also, when we look at programming, we say, oh, well, to live well, you need to be socially engaged, cognitively engaged, physically engaged. In order to do these things, we need systems and places which can support that. And it's surprising how less in quantity or how scarce those programs are across our country. You know, uh, we can go into a support group, but that support group, you need that support group to have those cultural and language considerations, right? One of the biggest thing is when you're living with dementia, as the disease progresses, you often forget your learned languages and you revert back to your mother tongue. So even if that person growing up had been in the country for 50, 60 years, was fluent, and I've met people who have had to go through where, initially after their diagnosis, they were able to go engage and participate in social programs. But as the disease progressed, they forgot their learned language, reverted back to the mother tongue, and slowly started getting socially excluded, which we know is one of the most detrimental things when it comes to living with dementia, is not just from the risk perspective, but also, once after the diagnosis of that social isolation. So I think having those systems where person feels safe, welcomed, and included is very important. And that's, I think, also across overarching thing is the trust. We need people to trust the spaces they're coming into. We need to welcome them and meet them in the spaces they are. And we often ask, we're like, well, why didn't you just go for a diagnosis? Why don't you just go talk to your local society or your local so and so organization? And it's always phrased as, why don't the people feel safe enough to come, from ethno-racial communities, come feel safe enough to come access resources, but it should be the other way around. Why have we not made the systems safe enough for them to be able to come to us? So it's the safety and the trust and creating those spaces which are welcoming, and they don't have to question, am I supposed to be here? Or is this where I belong? That should never be a question when they're trying to access services, especially for Alzheimer's and dementia. And I'll leave it at that. Thank you.
Thanks, Ngozi.
Just taking off of Ash and Nav's point, how do we create systems that are welcoming and trusting? And I'm going to be controversial here, so everybody on the call, forgive me, but for those that know me, it's right in line. How do we create systems that are trusting? Well, we have to actually acknowledge what these systems are. And these systems, as Ash said, were designed to operate as they have been operating, which is at the exclusion of groups. And even when groups come into the system, they're coming into a system that has been set up in a heteronormative, white, Christian, English speaking, male dominated way. That's just the reality of it. When it comes to the Black community, healthcare systems and social care systems have never been safe spaces, safe ideologies for us to engage with. Full stop. Enough research about that in the States and in Canada. Within the Black community, we have the worst health outcomes for a variety of reasons. And one of them is anti-Black racism. And I have to name it if we're actually going to be able to challenge it and do something about it. When we talk about anti-Black racism across the whole spectrum of society, when we think about dementia from a life course perspective, there's something called the weathering effect, whereby exposure to forms of racism chronically and acutely actually have an impact on the brain and on your ability to have cognition and cognitive reserves as you get older. And this has been documented in the States as well. We've seen that people who have been exposed to forms of anti-Black racism have a worse time aging and with cognitive function. Now, in the Canadian context, we don't have those stats, but we do see stats on health, Black communities reporting worst health outcomes. Now, individuals who work within these health systems have good intentions and they mean well and they want to do well, but they work in a system that doesn't necessarily understand the nuances and the realities of people within different communities, especially the Black community. And people may say, well, we're being divisive now. We're talking about differences and we're being divisive. We're not. We're being accurate, we're being factual, and we're trying to find a way to have equity and equality in our healthcare systems, and that includes naming them. Another thing I want to talk about is representation. Representation cannot be understated, as Nav has pointed out, when you have people that look like you, that come from your background, that speak your language, that understand your experiences. It is a remarkably different experience in the healthcare system. I can't count on how many times I've walked into long-term healthcare settings with my father and I see somebody Black, my shoulders immediately drop, my face is relaxed, and I'm able to engage in a different way because unfortunately there is an assumption that the healthcare system is not kind. And that's not because of just arbitrary, it's because of pattern recognition. And so when we think about dementia as a very vulnerable disease in a very highly stigmatized in vulnerable communities already, going into a healthcare service, a healthcare system, or a social care system that has already been proven hostile to you, you're gonna have your backup. There's gonna be a lot more apprehension in having these conversations and being able to participate in what's offered. And I have to say, the healthcare system can participate very explicitly in anti-Black racism, not giving the right diagnosis, not giving the right medication, not offering the right treatments, being very dismissive and critical of people coming into spaces looking for help. And so it's not because these systems have been created by people, they can also be changed by people. I want that to be very clear. When we talk about how to make it safe and trusting for different communities, it's upon all of us, everyone within the healthcare system and allies to it, look at ourselves and the system itself to say, how can we, maybe we have to deconstruct in some places and reconstruct in other places, but systems were created by individuals, which means they can be changed by individuals. And I'll leave it there.
Thank you so much, Ngozi. So we have some time now for questions as well. So I invite people to add those into the Q&A box at the bottom. We've got two questions that we'll get to in a moment, but I just want to ask our panelists first, and not everyone has to respond, but in recent years. We've been seeing kind of a backlash against equity programming and initiatives. So why, I think we've been articulating in various ways, and Ngazi, you just stated very clearly why this is really important, especially for members of the Black community. But why is addressing health equity in dementia space in Canada so important?
So a couple of years ago, the Alzheimer's Society of Canada, they released their landmark study, Landmark Study 1 and 2. And Landmark Study 1 was about the projection of dementia across the country writ large. And then Landmark 2 was the changing face or the new faces of dementia, which looks at these different populations when it comes to dementia risk and prediction by 2050. And so when we think about Canada as a nation, we are a nation of immigrants. We are a nation of diversity, which we take pride in. And we exclaim to the world, we are the most diverse nation, all the things. And so, from a moral perspective, it's incumbent that we support all people living with dementia. We have to recognize that not everybody, as we've articulated, is going to experience dementia the same. And they should in terms of getting access to services, but the reality is that they don't. So if we are true to our word that we are a multicultural nation and we want to support everybody living with dementia, so when we talk about getting to equality, as you showed in your first slide, Samir, we have to do equity. So some folks may need a little bit more to get to this equal level playing field. And it's not a zero-sum game where if we help one group, another group loses. That's not the way equality and equity go. If we help one group, we all rise. One tide raises all ships type of thing. From that perspective. From an economic perspective, Dr. Chambers, he released a report 2016 talking about the economic impact of dementia. Back then, it was like $10 billion a year and lost wages and expenditures for healthcare services in the systems. That's going to be more by 2050. So, from a moral perspective and an economic perspective, it does behoove us to understand that everybody needs access to the right supports, but in doing so in a way that makes sense to them. For when we talk about from a gendered perspective, we have women's health, and we talk about women's health. We talk about health for trans members of the community. We talk about health specifically for people related to their unique experiences. The same should apply when we talk about ethno-racial, indigenous, rural populations, 2S LGBTQ plus. Everybody does not experience dementia the same way. Dementia does not discriminate. The way we experience it can be discriminatory. So we need to do something about that.
Well said. Any other points people want to raise about like why is it so important that we need to do this work?
I think the point that I just want to like underline is that it's when we think about health equity, we think about equity, we think about recent conversations is that it is kind of being portrayed as a values statement versus an actual care quality issue. And so I think Ngozi beautifully put that care quality issue and the impact of not having that health equity lens and that health equity approach is that you see patterns of avoidance until crisis, you see delayed diagnosis, you see worse outcomes, you see system burden and system challenges. And so I think it's a question of who receives that timely, appropriate dementia care is really not separate. It cannot be separated from conversations around equity or health equity. And so to try and parse it out and minimize it based on our sociopolitical conversations and what rhetoric is being of the moment, I think we need to be really focused in on the quality of care. How are we raising all tides and raising all boats with what we're doing within the health and social care systems?
Well said. Perfect. Another question I wanted to, and we are mentioning kind of Ngazi, you were mentioning the diagram that we shared. One of our participants said that they said they've seen an updated equality equity image that also includes justice, and so and they use that with a metal see-through fence, and they said that could be very beneficial to advancing this narrative as well. So I welcome that comment as well in terms of how we're thinking again about the importance of these principles. It's not a zero-sum game. It's one where we all benefit together that way. But
I want to add,
oh yeah, go ahead. Go ahead, Ashley.
there is the evolution of that image where it does have the chain link fence that everybody can see through, but then you can take it one step further and remove that fence altogether.
Mm-hmm.
And so that is the work of equity, and that is the work of towards justice. So I think it's a really helpful diagram for folks to help conceptualize what we mean and then to distinguish between equity and equality, but also what we're working towards in terms of those barriers.
I just want to add just 1 second.
Go
Sorry,
ahead.
Ash.
Exactly.
Take off from that point. When we remove the fence, we're changing systems.
Yeah.
So it's really hard to do equity work in a system that doesn't want that to happen. So ultimately, we have to look at the system broadly, and healthcare is not divorced from any other system, education, housing. Health is part of all of our systems. So it's a revamping of all of it. It's about I hate to say it, being a justice warrior, but that's ultimately what it comes down to. Now you talk, 'cause I've been talking a lot.
Thank
Well,
you.
I'm gonna actually bring in another question here, and then we're gonna get to our other two audience questions. But there was also a comment here that that someone said, do we have are we truly representing diversity on our panel in terms of saying, what about the French view? What about our Indigenous community view too? I think we recognize Absolutely. These are all important views. And I think we certainly, our speakers have talked about the work that needs to be done, that these aren't just kind of only the representative communities that we're talking about. It's just that there's so much work in this space. So I just wanted to acknowledge that comment there. But okay, before now we've got three questions, other questions we have to answer. So, but well, I'll let you say your piece, and then because I think we'll go right into the questions then, because I want to, because one thing we were talking about preparing for this was this idea that we talk about people who immigrate, people with different languages, but well, if we all just kind of stick around long enough, we'll all be Canadianized, we'll all be, and then we don't have to do this work, right? So I just want to throw that in as, because I think there's kind of an understanding about why this work is important. But now, if you were going to say something, and maybe it ties to that point as well.
Yes, yeah, that's a really good point because I've personally heard that remark as a question directed at my research of why we're doing this work. And that person said to me, well, you're born and raised here. You dress fine. You speak fine. Like, why are you doing this work when it's going to become obsolete in the coming few decades? But before that, just around the systems, I wanted to add, I think one of the changes that needs to come is stop seeing equity as a nice to have or an add-on. It should be a central part, an inbuilt part of our system. When you see it as nice or nice to have or as add-on, it becomes very easy. It also almost comes off as a choice. Like, do we want to have equity or do we not want to have equity, right? And then that's where that funding ties in, where a lot of the programming that's happening, a lot of the resources and material that we're seeing coming is coming through this short-term funding. And once that funding runs out, that add-on gets removed. But if it's inbuilt into our system, then we don't have to worry about supporting a community or supporting people living with dementia from diverse communities from the sense that, oh, will this still be around the next year? Right? Because it takes time to build that trust. And it's not fair when that funding gets taken away. You're breaking that trust. And then a few years later, like, well, we're back. Do you guys want to come access services again? They're like, well, what changed this time? Right? So it's not helping that stigma, that lack of awareness we're trying so hard to address. But coming to that point about immigration, I feel that's something, regardless, it's culture is always a spectrum. You'll have people who were born and raised here, like even within my family, I have family members who were born and raised here, don't speak the language, don't relate to the culture, but then you have people who are in the middle, or some people who are recently immigrated. And just because people who in 2026 are in Canada doesn't mean that's the end of it, right? Immigration is going to continue. People are going to keep coming. And we know the way dementia and Alzheimer's work, it's research has shown you forget your, learned languages. So what about the people, I'm speaking English fine now, but what if in 60 years, with the onset of Alzheimer's, I'm no longer able to communicate in English. And, with our short-term memory, when you retain a lot of those long-term pieces. So even from a personal experience with my grandmom, she's at that point, she doesn't remember anything from her past 50 years in Canada. Every time she talks about her home back in India, right? So if nobody understands those pieces, nobody understands why that language as culture is important, then how are we supposed to support people? How can we support people from different communities? So it's very important to see this as a long term, as an infinite, if that's the right word. Like it should be a continuous thing, not something that's short term and won't be needed in the future.
Can I just add 2 points before we jump into the question?
Sure.
Number one, Nap, to your point, wonderful about equity is not a trend or a fad. So for everybody on the call who are programmers, designers, developers, policymakers, if you want to work with community in an equitable way, invite them in at the beginning. Equity is not an add-on you add after you developed your program, after you developed your policy. Now let's talk to community. No, community should be at the site, at the top of that, because that's how you do true equity work, number one. Number two, when we talk about why does it matter, you're Canadian? My question is for people to start thinking about deconstructing systems, why do we have to lose our identity and our culture to be in Canada? Why is it that because we're Canadian, born here or not, we have to forget everything else of who we are, what makes us us, to be a part of the Canadian complex when we say that we're a multicultural nation? So for folks that wonder, well, why do we have to do this? Why shouldn't we? Why is the default have to be the sort of white English speaking heteronormative? Why does that have to be the only way to be in Canada?
Perfect. Okay, now to our questions because we've got four. Well, people are adding questions in. Okay, hold on. So, One point here is, and so we'll keep the answer short because I want to get because we only have 5 minutes left. But so Ngazi, Mohammed says, Ngazi makes a crucial point. We built the system and we have the collective responsibility to change it. To build on that, reshaping our programs and resources effectively requires that us to reflect the true cultural diversity or involve deep multicultural consultation right now. And they say in brackets, and I'm not saying for every situation, but our focus unfortunately tends to center on the dominant ethno-racial demographic rather than intentionally designing from a multicultural inclusion lens. I think that's just reaffirming what you just said beautifully. Bethany, she asks, what are we doing at the student level, future medical health professionals, to remove some of the systemic barriers? Are medical and nursing students being educated on these issues as they will increase with an increase in dementia diagnoses in the near future? I think a little bit of work is going, but this is work that needs to be system wide and not kind of, as Nav, you're saying, an add-on, but something that is deeply integrated. I don't see much of it happening at the core level that it needs to. But Ash, Ngazi, Nav, anything quickly that you know of that's happening? Because I don't think much is happening, but I think it's better than we were, say, when I was training as a student 25 years ago.
Yes, I think definitely, Samira, so we're headed in there. We still have a lot of work to do. But one of the things I wanted to share, and I believe the link will be sent out later, I did share with the organizer, is there is this guidebook developed by UW Schlegel Research Institute for Aging. It's called the Guidebook for Engaging Ethno-Racial Communities in Dementia Research. And this guide beautifully sets up because it's almost like it becomes trendy, right? Oh, let's do ethno-racial research. Oh, we don't know about this. Let's go fill this gap. But when we're rushing to fill that gap, as Ngazi said, the communities get left behind, right? We don't involve them from the get-go. It's like when we get to the recruitment part, we're like, okay, now we need someone from the so-and-so community to come talk to me about their experiences. So there's this guide that talks about preparing yourself from the step one, engaging with the community from step one, checking in your own privileges, your own biases of how can you do this research in a meaningful manner? Because at the end of the day, it's not about you. It's about the community. How can we support the community? How can we make sure that the research we're doing is getting back to the community? So that's just one of the resources which and again, it's not encompasses everything. It's just part of what you should be doing, but it is a good resource to go through if you are in that research space, working in that dementia and equity space.
Perfect. I know David had made a comment about his work with deaf seniors, and he noted the importance of the idea of inclusivity, in this work, for example, and how that's an important key concept. And I think we all agree. I know Mohammed has asked a question, and I'm going to try and get these last two weaved in, but Mohammed and then Varsha's questions. But Mohammed had just noted, he said, has there been any study on cultural perception of dementia? He said, I can talk about my part of the world. Instead, in my part of the world, dementia is a normal phenomenon that happens to some individuals when they get old, a natural aging process. Therefore, it's just ignored as an illness, if you will. And I think there's been a lot of work on cultural perceptions that has been done,
Yeah.
but certainly these different perceptions, can be challenging as well. So, but I just want to get to Varsha's last question, which was my question is, what proactive work is currently being done at the system and infrastructure level to better prepare healthcare aging dementia services to meet the needs of culturally and linguistic diverse populations? And where do you see the greatest opportunities for community organizations, caregivers, and public engagement initiatives to help close these gaps? So, last points, team, where do you think the next big thing that we need to do to get this right?
Well, so with the Alzheimer's Society of Ontario, we focus on the Ontario population. NAB focuses on the Alberta population. And between her and I, we both have equity initiatives within our federations and as well externally. So different organizations. So David's question, ASO, we are working with some organizations that support the deaf and blind in Canadians around dementia awareness and programming. So there are sites where this is happening. Certainly talking with your local MPPs and really sort of driving the message home own, because we also need government support. We didn't talk about government, but we need government resourcing, government attention, and political support to get health equity on the agenda and sustained on the agenda. Students can do that as well through their schools. U of T has some wonderful equity-based programs as well. So does York University. I'm sure Ashland have a couple as well. So there are opportunities and avenues for that. Look out for them as they come up. We will be posting, Nav does, I do, I think Ash does as well. So there are some things that are going to be coming up for the general public to get involved in.
Perfect. Any final comments, Ash and Nav?
I think I just wanted to add a quick thing as we move forward with improving dementia. I think we really need to start understanding that it's good to translate stuff, but translation is just scratching the surface. It's very important to adapt these resources, co-design these resources, get the communities involved. If you're developing something for the Black community, you feel like a resource is needed, involve them. Don't take an existing resource, switch out some photos and examples and call it, oh, this we have done this work for you, right? That's not going to speak to the community. I think it's really important to understand translation. Yes, sometimes that's the best we can do with the resources. It's a bigger issue of funding, but where and when possible, co-design and adaptation should be the go-to versus just translating material.
Brilliant. And Ash, final words?
Yeah, I think I totally agree and put an exclamation point on the parts around engagement and co-design, and bringing folks into the fold at the start of work that we're doing and not just adding them on after. And then I also want to say there's a lot of resources that are now currently being shared in the chat if folks want to do the work. And I encourage you to do the work to learn more about the various communities that are experiencing the stigma and barriers and lack of awareness when it comes to dementia care, and reaching out to health and social care systems and services. So there's lots of resources there. I, in particular, there's an e-course around 2S LGBTQI experience of the dementia, and how to better support and meet folks in their journeys there. So I'll just leave it there.
Perfect. So I want to thank each of my fellow panelists today, Dr. Ashley Flanagan, Ngozi, and Navjot as well. And I just want to say thank you to each of you. I also want to say a shout out to Dr. Tara Graham, who has been doing a lot of the work behind the scenes to help prep for this webinar, and help recruit our panelists today. And a lot of this work is going to be helping to shape a forthcoming report we have on dementia care in Canada that'll be coming out this fall. So thank you to our panelists, thank you to Tara, and thank you to the team at the NIA who's helped to put on another terrific webinar that really just, again, starts to raise awareness about something that is not a one-time thing, but needs to be a deep, ongoing thing that we can do. So as Ngozi said, so that people, their shoulders can drop, they can feel relaxed and be seen, so that we can give people the care that they actually deserve. So thank you very much, everyone, and take care, everyone. And thank you for tuning in. And we'll see you at our next webinar.